Hi, I'm Dr. Amitabha Mitra. I'm going to talk to you today about Dupuytren's disease. This talk basically will cover most of the information you want to have about Dupuytren's disease, including the cause, pathogenesis, genetics, uh, treatment options, both conservative and operative treatment, as well as most of the questions which are commonly asked during your board exam. If you have any questions later on, please write a comment. We'll be glad to answer. Or if I have to modify this information, I'll be glad to do it. So let's start with the Dupuytren's disease. Dupuytren's disease was described by Baron Dupuytren in 1831. This disease is a progressive connective tissue disorder of the palmar and digital fascia. The fascia thickens and develops into cords. You also develop pits and nodules. In theory, pits and nodules are the earliest sign of Dupuytren's disease, but in clinical practice, you really don't see that very frequently, pits. Nodules you do. As the disease progresses, the cords, it contracts even more. As it contracts, the resulting contracture brings the MP and PIP joint in flexed position. Typically, the disease starts on the ulnar side of the hand, namely ring finger, long finger, and little finger. Though we see it in the index and thumb and first wave space from time to time, but mostly it's an ulnar-sided disease. It's 8 to 9 times more common in males. It's associated with alcohol abuse in about 10% of the people, diabetes in about 8% of the people. Some of the patients with epilepsy, about 2%, has signs of Dupuytren's disease. But remember one thing, it may not be anything to do with epilepsy, but it may have something to do with the medications they take. It also has association with smoking, HIV infection, myocardial infarction, and hypercholesterolemia. By the way, the indexed patient which Dupuytren wrote about this disease was his coach driver. The contracture occurred in the hand he used to hold the whip. This may be the initial association with repetitive trauma which Dupuytren thought it's of traumatic origin, period. Some, but not all the studies, shown an increased incidence in manual labors of Dupuytren's disease, but trauma may exacerbate, but it's not the cause of the disease. Genetically, this is most common in a Scandinavian population, in UK, USA, Canada, and Australia. As you already know, this is called as a Vikings disease because it came from those areas. 27 to 68% of the patients report a positive family history. It is supposed to be an autosomal dominant disease with variable penetrance. Trisomy 8 in some of the involved fibroblasts are identified. Some involved fascia expresses androgen receptors. Patients more commonly express HLA-B7 and HLA-DR3 predominance. The aggressive kind of Dupuytren's disease occurs in patients where it starts before the age of 40 in women, patients who has a positive history of family history, or when they show up with involvement of both hands, or involvement on the radial side of the hand, or involvement in various sites, namely hand, feet, or penis. Dupuytren's disease generally affects the quality of life. Patients report difficulty with grip, difficulty in putting hand inside the pocket or tight spaces. They have a day-to-day activity can be impaired because of the contracted finger. It may interfere with the ability to shake hands. Nodules sometimes can be painful. Late disease may cause problems with hygiene or skin maceration, especially when you have got a strong or advanced MP and PIP joint contracture. It may interfere with employment because people cannot make a grip in these patients. What is the pathogenesis? Essentially, it has type 3 collagen. One has to remember this because this is a board question which is asked every single time. There is a proliferation of fibroblasts. Fibroblast growth factor increases. Transforming growth factor alpha increases. Epidermal growth factor is there. Interleukin 1, platelet-derived growth factors, fibronectin connects myofibroblasts to one another, collagen and extracellular matrix all are involved in Dupuytren's disease. In the early proliferative phase, transformation of fibroblasts to myofibroblasts. Vertical bands of connective tissue gap rose fibers develop into cords, and the dermis becomes adherent to the fascia, resulting in pits. In the intermediate or involutional phase, myofibroblasts coalesce to produce nodules attached to the skin and fascia. The nodules have an increased ratio of type 3 to type 1 collagen. Myofibroblasts align in the direction of stress and form cords. The number of myofibroblasts begin to decrease as it matures and collagen concentration starts increasing. The cords start to become more dense and more stiff. Knuckle pads can also appear at this stage of Dupuytren's disease. In the late phase, there is little metabolic or mitotic activity. Contracture usually starts at the MP and progresses to the PIP joint level. Most common, the fingers which are used or gets involved are ring finger, small finger, long finger, index, thumb, and first web space can also be involved. Normally, remember one thing, that the bands are normal in hand, namely pretendinous band, etc. When we talk about cords are basically pathologic. The second information which is important, there is no central band in the hand, but there is a central cord. So pretendinous band becomes pretendinous cord, but there is no central band. So pretendinous band, as it progresses towards the MP joint, it becomes central cord. Disease involves the palmar aponeurosis and its digital extensions. Grayson's ligament, lateral digital sheath, pretendinous bands, natatory ligament, spiral bands are all involved. And I'll show it during the diagram exactly which one is what and how the whole process involves. Contractures are caused by pretendinous and central cords as well as spiral cords. And again, I'll show it to you in the diagram. Cleland's ligaments and superficial transverse ligaments are usually not involved, whereas Grayson's ligament is involved. To remember which ligament is involved or not involved, Cleland kind of sounds like clean, so keep in mind the Cleland's ligament doesn't get involved. Pretendinous cords occurs in the palm. It's the transformation of the pretendinous band which becomes pretendinous cord. It arises obviously from the pretendinous bands. Central cord, there is no central band in the hand normally. It occurs between the neurovascular bundles of the digit. The area is a continuation of pretendinous cord. So the pretendinous cord extends distally and it becomes central cord. It attaches to the proximal phalanx, the second, or rather the middle phalanx and the flexure sheath period. Pretendinous cord and central cord causes MP contracture. Natatory ligament, which brings the metacarpal joints together, gets involved, causing a contracture, and this is regarded as a natatory cord. Spiral band becomes spiral cord or retrovascular cord. It arises from the spiral bands, displaces the neurovascular bundle anteriorly and towards the midline of the digit. It's important to know this information because this neurovascular displacement of the digital nerves, which comes centrally and polarly because of the retrovascular cord and spiral cord, becomes more prone to injury during surgery or especially percutaneous division of the band because they are displaced from its normal habitus, period. With central cord contributes to the PIP contracture because it's extending more to the middle phalangeal level. With the lateral cord, which goes all the way up to the distal phalanx, it contributes to the DIP contracture. This also may cause recurrent contracture because of this retrovascular cord as well as the lateral cord, period. Lateral cords arise from the superficial fascia of the fingers, lies lateral to the neurovascular bundle, and the fibers travel distally to contribute to the DIP joint, causing DIP contracture. So, to summarize this, basically is NP joint contraction happens by central cord and tendinous cord, pretendinous cord. The central cord also causes PIP contracture. Lateral cord, which stays lateral to the digital neurovascular bundle, that goes all the way up to the distal phalanx, causing DIP contraction. This is the diagram which one has to remember. This is the normal band. This is pretendinous band. There is no central cord here. So this becomes, as the disease progresses, into a central cord. Spiral band becomes spiral cord. It divides into two basically and goes into the lateral digital sheath underneath the neurovascular bundle and involves the Cleland's ligaments on both sides. So pretendinous band slowly becomes pretendinous cord becomes central cord extends all the way up to the middle phalanx. Spiral band goes on the side and then it gets attached to the lateral digital sheath, which is underneath the neurovascular bundle, and this contributes to the this gets attached to the Cleland's ligament, both. Remember, Grayson's ligament, which is in front of the digital neurovascular bundle, never gets involved, period. Grayson's ligament doesn't get involved. Transverse ligament, here, it becomes natatory ligament or natatory cord, which brings the two metacarpal bones together, making the abduction of the finger difficult. Again, progression of the disease, if you look at it, pretendinous band has become pretendinous cord. It has extended to become central cord. Spiral band has become spiral cord. Spiral cord has got involved in the digital neurovascular sheath and then gets involved into the Cleland's ligament. Again, Grayson's ligament doesn't get involved. Again, pretendinous band becoming pretendinous cord, spiral band becomes spiral cord, lateral digital sheath becomes lateral cord, and essentially the Cleland's ligament goes onto the top. Same principle. The only visualization is digital neurovascular bundle has been brought forward, volarly, as well as centrally. And that's the reason any incision of any attempt to either do a fasciotomy, percutaneous, or during surgery, this area becomes vulnerable to injury. This is the advanced picture of how the pretendinous cord, the spiral cord, gets involved. Now, keep this picture in mind in one way that see this band, this is called lateral cord. Is the lateral digital sheet goes up there, it becomes a lateral cord. Lateral cord gets attached all the way up to the distal phalangeal area. So if you think about it, pretendinous cord, central cord, they flex the MP joint as well as PIP joint. Lateral cord on the other side flexes the DIP joint. This is when the situation is pretty much advanced. Treatment options can be non-operative or operative. The non-operative treatment can be by giving the patient allopurinol, doesn't work too well. Calcium channel blockers, doesn't work too well. Sometimes local injections of steroid might help by eliminating the pain to some extent. Enzymes, we'll talk about it. DMSO, topical vitamins, doesn't have too much of an effect, period. Other modalities, which is important in the early stage at least, is splinting and traction protocols, and even post-operatively is the same. Ultrasound and radiotherapy may be advantageous, but hardly anybody does any radiotherapy. Xiaflex is a medication which we'll talk about it a little bit because this is coming onto the TV all the time. This is a collagenase Clostridium histolyticum. It's an antigen which dismantles the collagen. Remember, this is an antigen. Every antigen will produce antibody at some point. The indications have changed over years. Nowadays, the indication is this. You have one single joint can be, or one single cord can be injected at a time, and you can only give about 3 injections because the body develops antibody, making the drug less effective. It used to be you can inject all 3 digits. That whole rule has changed recently. This Xiaflex, about 90% of the MP contracture and 50% of the PIP joint contracture may respond in about 4 weeks' time. Up to 3 injections may be required, period. At 5 years, there is about a 10% recurrence rate, which is a pretty significant number. The complications included skin tears, skin ruptures when you try to straighten the finger out, which is done within about 24 to 48 hours time. Local swelling, local bleeding, pain, lymphadenopathy, and tendon rupture. Tendon rupture is a very serious issue. If the Xiaflex gets injected into the tendon, tendon weakens and tendon rupture. That becomes completely different problem because ruptured tendon will end up having what we call it a tendon transfer surgery, which has got a reasonably unpredictable outcome, period. Patient satisfaction may not be as good as previously claimed, and it may be costly to the patients because of their insurance coverage. Patient may have to have a larger amount of copay. So one has to be careful and select the patients carefully so that the treatment options or non-operative treatment options suits the patient and it's basically financially not a burden to the patient. Operative treatment is indicated to improve quality of life or address a specific complaint. Treatment is individualized. A biopsy is not needed. Usually considered surgery for MP contracture greater than 30 degrees or a PIP contracture greater than 10 to 15 degrees. Operative treatment of fasciotomy, not overall fasciectomy, etc. Fasciotomy, which is done percutaneous, it has a recurrence rate of about at least 50%. So your selection of the patient is going to be important. MP joint respond better than the PIP joints, and the patient determines which hand has to be treated properly. Fasciotomy involves basically cutting the offending cords without excision. That's why you have a higher chance of recurrence. Can be done through a series of incisions or percutaneously with a needle, period. It requires local and or MAC, indicated for minimal disease or for patients who are not fit for a more extensive operation, period. Rehab is minimal, Patient satisfaction is very high. Recurrence of symptoms are common, and nerve injury is the primary complication of percutaneous fasciotomy. On the other hand, fasciectomy has a lower recurrence rate, less than 15%. Fasciectomy is more extensive operation. Regional anesthesia and MAC is required. Rehab after operation is more extensive, period. Limited or regional fasciectomy can be performed. At times, because of absolute adherence of the skin with the Dupuytren tissue, a dermofasciectomy may have to be performed. Limited fasciectomy is the most commonly performed procedure. Dissected fascia is removed via the incisions in the palm and fingers. Normal fascia is left alone and it's not excised. A wide variety of incisions are possible. Most of the people do zigzag incision so that the scar contracture doesn't happen, period. Incision may be left open to heal by secondary intent, as we call it a Makash's procedure. It reduces the risk of hematoma and flap necrosis, has been associated with less postoperative pain, and may result in improved range of motion, though the healing time can be significant. Dermofasciectomy is indicated when the skin is densely adherent to the diseased fascia. It's also used for patients with recurrent or severe primary disease, may have the lowest recurrence rate out of all the fasciectomy which we do. Wound closure may require a skin graft and or flaps. Some people experimentally has used allograft between the skin and the excised tendon. We don't have that much data to talk about it. These are some operative pictures which basically shows just a cord essentially involving the long finger in this patient. That's the cord, as you can see in this patient again. And after excision, postoperatively, this is the Z incision, it essentially heals up normally, and as you can see, there is not much of a contracture left in this patient. Flexion movement is also satisfactory. The adjunct techniques could be sometimes with a PIP contracture or MP contracture, you may have to add up capsulotomy or volar plate release. Temporary fixation of this extended finger with a K-wire for about 2 to 3 weeks. Implant arthroplasty may have to be done in certain patients. Arthrodesis may be needed in some patients. Osteotomy may also be needed in some patients when the contracture is not easily relieved. Amputation is usually indicated for severe multi-level contracture that cannot be corrected, or the patient has had a neurovascular injury already. The complications of operative treatment early, it could be hematoma, neurovascular injury, skin flap, necrosis, and wound problems. Skin graft loss, if you put a skin graft on the top during a dermofasciectomy, or infection. In the late, patient may have chronic pain syndrome, patient may have recurrence of the disease or contracture, and inclusion cysts, which are not very common. Postoperative care, essentially early postoperative visit is needed to assess the skin healing, hematoma, flap loss. Extension splints are usually used for about 4 to 6 weeks, at least at night. Exercise protocols are useful for most patients. Operations for the PIP joint will require specific therapy, especially active passive range of motion, stretching, etc. Wound complication and skin grafts and flap may require additional splinting at some point. Thank you. If you have questions or concern, please let us know or just write a comment. We'll try to modify our approach to some extent. And if you like it, please subscribe. We'll have more topics on plastic surgery and hand surgery as in future. Thank you.